to our AETCM channel. Shall we start?
Yeah.
70-year-old male patient who came to our ER with complaints of coughing up of blood 2-3 episodes since yesterday. On initial 10-second assessment, airway was patent, no pooling of secretions or gurgling. At this point, we put the patient in a propped up position at 30-degree head and elevation. Coming to breathing, respiratory rate is 18 per minute, SpO2 is 96% in room air, air entry bilaterally equal and no added sounds. Circulation wise, BP is 160/80. Pulse rate is 82 per minute. At this time, we insert 2 large bore IV cannula. Disability GCS is 15/15, pupils bilaterally reactive, and exposure patient is afebrile and GRBS is 150 mg per dl. Adjuncts to primary survey, we do CBC CRP to know the total count and CRP to look for any infections. And CBC CRP, HB is 11 mg per dl, TC is 6000, platelet is 1,82,000, CRP is 5.2. And we also done VBG to look for any acid-base abnormalities, but there are no acid-base abnormalities. Sodium, potassium, electrolytes, everything normal. Sample history, 70-year-old male patient, non-case of hypertension.
Chest X-ray?
We do chest X-ray. There is mild shift of trachea to the right side.
Is that normal? What is the normal level of trachea? A little bit to the right side. Minimal it is there. So if it is more than that, you have to take it as...
there is only mild shift. There is no homogeneous opacity, no increase.
Okay. When you have a shift, you are saying shift of trachea to the right side. So what is your concern?
Sir, is there any consolidation or any mass on the...
Why you should have a puddle of trachea to the right side?
Either fibrosis on the side to the side of the shift,
okay,
or any mass or lesions on the other side.
Usually the classical one is the tuberculosis one. In India, we have to suspect tuberculosis. We have an upper lobe involvement, cavitatory or upper lobe fibrosis. That as a part of tuberculosis, previous history of tuberculosis, there can be slight pull of trachea to the right side. If it is significant pull, you have to be very cautious. And another thing is, when you are having an X-ray showing a probability of an old TB, active TB may not be there, and changes of old TB, a cavitatory lesion, and patient is coming with hemoptysis, we have to suspect what? Rasmus and aneurysm. So that is the most correlation. Just since you said regarding X-ray, this is what I saw. Usually you are looking for any masses, metastasis, fibrosis, any evidence of tuberculosis. That's how an X-ray might help you during that time. Anything else that you can gain from the X-ray? Hemoptysis and patient coming with ED with hemoptysis. What all things can help you other than what I have said from an X-ray? You think what are the other causes of hemoptysis? Okay, pulmonary edema, bronchiectasis. You can look for changes of bronchiectasis then. Pulmonary edema you said. Alveolar hemorrhage, okay. Then. Pulmonary embolism, one important thing. You can have a clear chest, Hampton's hump, all those things being said, I have never seen. To be very frank, I have never seen Hampton's hump and all. Infracted lung being pulled up, I have never seen. So pulmonary embolism presentation with hemoptysis is one important thing. Then, what else? What are the other structures that you can see from the X-ray? What are the other structure? Arch of aorta and hemoptysis. The patient very rarely it can come. We have an tracheoaortic fistula and patient can come with hemoptysis. Yes, it is one of the dangerous reason why you are having an hemoptysis. But from the arch of aorta, we will not be able to gain the fistula and all. You will not be able to understand. See the hard borders, mitral stenosis. One of the other causes you have to look for mitral stenosis. See the straightening of the left heart border. How is the heart border? All those things you can look into. So you will get an idea by looking into that X-ray. Whether there is a gross cardiomegaly, anything is there. Whether if there is a straightening of left heart border, so that indicates a left atrial enlargement. So left atrial enlargement will signify that probably the patient is having a mitral valve pathology. Mitral valve pathology, that's what I am saying, mitral valve pathology. Then you need to evaluate it further. So that is how helpful an X-ray can be in case of hemoptysis. Okay, then go ahead with the sample history.
70-year-old male, non-case of hypertension, who was a chronic smoker for the past 30 years and stopped for past 3 years, presented to the ER with the complaints of coughing up of blood 2-3 episodes from yesterday onwards, with each episode contained 20 to 30 ml of blood mixed with sputum, and the last episode consists of clots. Also complaints of intermittent fever and cough episodes for the past 2-3 months, each episode lasting for 1 week, which evaluated on a OPD basis and subsided by oral antibiotics. This last episode of cough with mild expectoration started 2 days back without fever in the current episode. No past history of hemoptysis, no history of any diurnal or postural variations, night sweats or weight loss, no history of decrease in appetite, no history of orthopnea, PNB, pedal edema, no history of trauma to the chest or any iatrogenic procedures or any surgical, and no history of immobilization.
Weight loss?
No history of weight loss, sir. No history of drug abuse. Allergic, not allergic to any medications. Patient is non-case of hypertension on tab telmisartan 40 mg BD, not on any anticoagulants.
And antiplatelets. Not on any antiplatelets. Okay.
Last meal is around 2 hours back. On examination, patient is conscious and oriented, no pallor, no pedal edema, no lymphadenopathy. Oral cavity, there is no bleeding as such from the oral cavity, there is no nasal bleeding such. Coming to the system, respiratory system, trachea, on palpation, trachea is central.
On palpation or it is central?
Found it as central. There's mild deviation index.
Okay.
Shape bilateral, symmetrical, no drooping of shoulders, adequate chest rest, no scars present on the palpation. Also, trachea found to be central. Vocal fremitus equal, percussion all areas equally resonant. Auscultation, rendering is bilaterally equal, no added sounds. Vocal resonance are also equal on all areas. CVS S1 S2 present, there is no added sounds, no murmurs. Per abdomen soft, non-tender, no hepatosplenomegaly. CNS, no focal neurological deficits.
Okay.
We manage the patient with
let's hold on here. Now we have to differentiate whether our management aspect will depend upon whether it is a hemoptysis or whether it's a pseudohemoptysis. So pseudohemoptysis, what are the main causes for a pseudohemoptysis?
So bleeding from the nasal cavity or
you can divide it again into two. You can divide into upper GI and you can divide it into from the nasopharynx, as you said, upper airway, or it can be from the upper GI tract. So what are the other things that you can ask for history of melena? Whether the color of blood is frank, whether it is black or coffee ground vomitus, mostly it is in favor of what? It is more foil of an upper GI bleed. Okay. So again, you have any upper respiratory infection. So you can have an oral cavity inspection, which is very important, which you have not mentioned. Examining the oral cavity is the most key thing. Examining the oral cavity and oropharynx, any gingival hyperplasia, anything that you are seeing, any active bleeding spotters and all those. Examination of the oral cavity is very key, and you can just simply put a torch and examine the oral cavity. That is enough. You have a laryngoscope and doing, but not ideally for this patient. But upper nasopharynx, you need to definitely evaluate to look for any of these things, because we don't have any. Only thing what I got positive from this patient is a history of frequent fever, cough in between since last 1.5 months to 2 months. So, which is not completely subsided. So, tuberculosis is still one of our differential diagnosis, and not resolving pneumonia since last intermittently coming and going when they are giving some drugs. Why that history would have given? Because you might would have taken some antibiotics, mostly levofloxacin or something if he has taken, which has got some anti-tubercular effect also. Maybe because of that, any of this medication that might have subsided, then again it is coming back. We don't know what medication he has taken. So unless and until proven, we think that okay, probably a tuberculosis might be one of the lower down. I'll keep it a little bit as the first differential diagnosis, because and another second differential diagnosis will be what for you? Second differential diagnosis will be a primary leg malignancy. Definitely somebody is coming with fever, hemoptysis, in between fever, cough and hemoptysis, not much of an infective etiology. We have to definitely look for a probable malignancy. So, being a smoker, already being a smoker, that risk is still on the higher side. And what are the other causes? That cardiac causes unlikely, pulmonary embolism unlikely. What are the other potential causes that you can keep a little bit higher up?
If an acute infection, acute bronchitis.
Okay, acute bronchitis can precipitate and okay then. What are the common causes? When we see in emergency room, when we see a hemoptysis, three important differential diagnosis we should be ruling out, because these are three dangerous things that the patient can deteriorate suddenly. One important thing, what I have already told, tracheoaortic fistula. Then what is the other one? The patient on a tracheostomy. Tracheo-innominate artery fistula. So that is the another one which is very dangerous. And third one is pulmonary embolism. So these three things are the deadliest things that we can have with the hemoptysis. As an ED physician, our priority to understand which are the life-threatening emergency and to need to differentiate between all those things. All those things. So that is the most important one what we need to take care of. Then the next thing we need to say whether massive hemoptysis or not. Massive hemoptysis, rather than telling about the volume of blood, it is the presentation of the patient. What will when I am telling massive hemoptysis, I am not quantifying the amount of blood. So 500 to 600 ml of blood loss, you look at the standard textbook, 1000 ml to 600 to 1000 ml, they say it as massive hemoptysis. But rather than seeing as a massive hemoptysis, we can say this way: the patient is unable to clear the secretions. If the patient is otherwise conscious oriented, if the patient is able to bring out the blood, it is okay. So the airway is patent, but the patient's sensorium has deteriorated. So I will call that patient having a massive hemoptysis. Airway is not secure. The next group of patient will be where there is already hypoxia have set in. And finally, the last thing will be hemodynamic compromise, which is not very common in a patient with hemoptysis, unlikely in hematemesis, where we will have massive amount of blood loss. And here 1000 ml of blood loss, even if you say massive hemoptysis, going a hemodynamic compromise will be not very commonly that you see. So when the patient is affecting his clearing of the airway because of low sensorium, or the patient oxygenation is not maintained, or the ventilation is also not maintained, that is the time when we need to really intervene and you need to think of intubating that patient. So massive hemoptysis we will put that way, rather than telling about the quantity of blood that the patient is having. Okay, so that is regarding massive hemoptysis. Now coming to the management aspect of this patient. Now this patient is not having any massive hemoptysis, only very minimal hemoptysis mixed with sputum. So we have differentiated whether it's a hemoptysis or pseudo hemoptysis. From the history, whatever you are giving, it can be from an upper airway, but we are examining the oral cavity is clean, and there is unlikely from an upper GI source. So upper GI source is out and our upper airway is also out, nasopharynx and all those things is out. Now we are probably saying that it's a true hemoptysis. True hemoptysis, it's mixed with the sputum. The classical thing, it is mixed with the sputum. You are able to see streaky blood, that is the patient is complaining of. Now you have put that, okay, this patient is probably having a true hemoptysis. From this, your decision will depend upon the hemodynamic stability and the airway, breathing, circulation, whatever you have said. Now this patient is stable. So how will you proceed further?
Stable.
What are the treatments that you can offer for a patient in the emergency room? Ideally, this patient, I will just keep him calm. That is the only thing that I will do right now. I will not put him on any other panic, these things, because it will become more and more and the patient will cough out more amount of blood. He need to keep him calm. And next thing,
we give anxiolytics and we can give cough suppressants and we can nebulize with the tranexamic acid.
Okay. Nebulization of tranexamic acid. So there is no major RCT supporting this. Only there is one RCT maybe 6-7 years back which has supported a high dose of 1 gram to 2 gram. 1 to 2 gram of tranexamic acid as a nebulization, supporting for the management of hemoptysis. IV you can definitely give. There is no contraindication. IV you can next give. And the next important question what I will ask is whether the patient is on any anticoagulants. Since you have already said he is not on any anticoagulants, I will be safe. Otherwise, my target is to bring down the INR and see the see the fibrinogen level, and if needed, give FFP, vitamin K, depending upon whatever agents that is consuming. And if platelet is less than 50,000, transfuse platelet also. So that target is also, you need to keep that in your mind. So anticoagulants, patient is on anticoagulants, look at the INR less than 2, you should be maintaining. 1.5 above, you need to treat that also. And then platelet count you need to look in for, and fibrinogen is low, you need to transfuse cryoprecipitate and FFP depending upon the situation. So that is the next important thing. And then now our aim is to look at the cause of hemoptysis. So how will you differentiate the cause? Primarily it is from one of the bronchial artery. When the patient is having, you have ruled out your upper airway, you have ruled out your upper GI, then the blood has to come from one of the bronchial arteries only. So how will you evaluate it further?
So Initially, imaging chest X-ray, and after that we can do chest CT angiogram to look for the any active.
CT chest will be a first important thing. CT chest with the CT angio. So CT angio you can definitely look into. Now, since the intervention radiology has very grown up to a good extent, you can think about if the patient is coming specifically with massive hemoptysis and all, you can always keep the patient NPO and plan for a bronchial artery embolization also. So, and again, one more thing that you want to intubate a patient is the patient is having hemoptysis. You are sending him out of the ER and you think that his airway can get compromised during an imaging time. So at that time, maybe an elective intubation you can do from the emergency room. Okay, intubation we will discuss it later because the techniques, everything is little bit different from the routine intubation. So we will discuss that later. So CT chest will be the next most important investigation along with an angiogram. Obviously, you can look for any other major bleeding sources, but if it is a small blood vessel hemorrhage and all, we might not be able to find it out specifically for this patient. Why I am doing a CT chest? Mainly to look for any mass lesions. That will be my primary intention. With a contrast study will be an ideal thing, and the next option will be an bronchoscopy. That will be the next option. Maybe an elective bronchoscopy, the patient can go in. So, since the patient is a very stable category, we can admit him and we can evaluate him, all those things. But once it comes to the massive hemoptysis category, you need to start your resuscitation straight away from the ER. So, how will you plan your intubation for this group of patients when they are in the emergency room? Intubating a patient with hemoptysis, it is not like you are going into the airway and you are going, and most important thing, either you do the standard RSI or video laryngoscopy. That will be an ideal assisted, or even bronchoscopy assisted intubation can be done. Only one key thing that you need to remember is that you need to have large suction catheters. Your classical Youngers won't be enough. So like we discussed, for an upper GI bleed, you can either connect the meconium aspirator behind your endotracheal tube, or there is something called a Salad technique. You can have suction assisted laryngoscopy. You can also think about, you might need two suction devices. Imagine that one suction won't be sufficient. The routine Youngers itself is small, so don't think about the routine suction devices at all. So you need to have a good meconium aspirator connected to the behind the ET tube. So whenever you are seeing the ET tube itself, through ET tube itself, we can suck out the blood and you can visualize, and you have to look for any active hemorrhages while you are intubating. Then the question comes, what are the drugs that is ideal? Ideal drug will be ketamine again, because always whenever it's a respiratory parameter getting involved, ketamine is an ideal drug of choice. So you go ahead with ketamine. And another important thing, the patient is able to tolerate. If they're able to tolerate the procedure, even just with a ketamine, you can intubate, try awake intubation also. Bronchoscopy guided awake intubation. You can look where exactly is the bleeding and all. But when emergency physician, our intervention, as I told, when the airway is not getting cleared off, the patient is a little bit drowsy. During that time, we need to go ahead and intubate the patient. So during intubation, you pass on the bougie, you look for any active hemorrhage, you see whether any major, usually it will not be seen in the trachea, it will be much more either from the right bronchus or from the left bronchus is the major thing. So you go ahead and intubate. One important thing you can plan is main stem bronchus intubation, either on the right or on the left. Now, how will you decide which bronchus to be intubated? So that is a question. So we need to know from where the hemoptysis is coming. So you first go ahead and intubate the right mainstem bronchus. Naturally, when you intubate and you proceed your endotracheal tube or bougie little bit anteriorly, it will go on to the, passing the carina, it will go on to the right mainstem bronchus only. If you are not seeing any blood in that right mainstem bronchus, you keep it there. So the hemoptysis might be coming from the left side. You understood? So you have seeing blood, then you need to pull out the ET tube. Why we want to do this? We don't want to contaminate the other lung by getting to the blood. So if it is diffuse alveolar hemorrhage, there is nothing you can do. Both the sides you will have active hemoptysis, active blood coming out. But it's a unilateral hemoptysis. For example, you intubate the patient, you introduce your endotracheal tube into the right mainstem bronchus, and if you are not seeing any blood, keep it on the right mainstem bronchus itself and keep a lower tidal volume for your intubation. Suppose you are seeing blood coming out from the right side. So withdraw it, take your bougie, then that is a challenging thing. You have to intubate left mainstem bronchus. So intubating a left mainstem bronchus is a little bit challenging because you need to direct your bougie head, the coda end of the bougie, towards the left side. So you need to rotate it 90-degree clockwise direction, and then you need to, because it might take 2 or 3 attempts, it will not go very easily to the left mainstem bronchus because it is more aligned to the right mainstem bronchus. It will easily go to the right mainstem bronchus. But when you have to intubate the left mainstem bronchus, you need to rotate to 90-degree, then you need to proceed it further to the left mainstem bronchus, then you need to intubate the left mainstem and see whether there is no blood. If there is no blood, that is fine, you fix it. So you know that the bleeding source is from the right bronchus, right side. So that is the major thing that you need to keep. Mainstem bronchus intubation is very important. It's a very important. There are even specialized tubes for this, but you have to understand intubating mainstem bronchus and mostly select the ET tube size above 8. Because if you are selecting even if it's a female patient, you select an ET tube size of 8. Because the next important thing what we need to do for this patient will be a bronchoscopy. So bronchoscope won't pass if the size of the ET tube is less than 8. So make sure that you are putting at least 8 size ET tube for the above 8 for this group. If it is 9, well and good for these group of patients who's coming with hemoptysis. So that is a very important decision that we have to do. Because once we are intubating the patient, if it is, go ahead and intubate the right mainstem bronchus, no bleeding, leave it there. If there is active bleeding, pull out, get the bougie in again, rotate it 90-degree, then guide it to the left side. Maybe 2 or 3 attempts is needed, and left side, then intubate your left side, and then you keep it there. Then you go proceed with CT or bronchoscopy guided treatment or interbronchial artery embolization, all those things, and continue on your resuscitation, hemodynamic resuscitation, whatever it. If you need to give a reversal agent and all those things, you can go ahead and add on. You understood? So that intubation is little bit different from the normal intubation what we practice in the emergency room. Another things, anything else that you want to add? So can you just summarize how will you approach a patient coming to with hemoptysis in the emergency room?
So first we have to quantify whether it is a true hemoptysis or pseudo hemoptysis.
Okay.
If it is a true hemoptysis, we have to look into whether it is a life-threatening one or stable one. If it is a stable one, we can manage it with anxiolytics. We can give cough suppressants, tranexamic acid, IV can be given. We can check for the
also nebulization.
Nebulization can be given. We can check for coagulation parameters. If it is any derangement, we can correct it with if there is platelet, we can give platelet, fibrinogen, FFP can be given. Injection vitamin K can be given, and further we can evaluate for the cause of the hemoptysis. For that we can do chest X-ray, we can do CT chest with angiogram, and if there is any active bleeding, we can do embolization can be done, and we can proceed with bronchoscopy. In CT we can also look for masses and all. We can proceed with bronchoscopy. If the patient is in a life-threatening condition, we can follow airway breathing circulation pattern. If the airway is compromised, we can intubate. There is a difference in intubation. We have large bore ET tube needed, and we also need large suction devices. Active suction is needed. We can intubate, and after that we can proceed with CT chest angiogram, bronchoscopy, and we can control the bleeding through bronchoscopy. We can control either through Fogarty balloon. We can inject sclerosing agents to control the bleeding. Okay.
So tracheostomy with hemoptysis, the worst one. A patient on tracheostomy, we have already discussed a case on tracheostomy. Patient come with tracheostomy and hemoptysis, bleeding from the tracheostomy size. Because the most common, it can be tracheo-innominate artery fistula and tracheo-aortic fistula and pulmonary embolism. 3 life-threatening ones that we need to keep that in your mind. And what is massive hemoptysis? Volume, yes. Not maintaining the airway, not maintaining oxygenation and ventilation. Or you want to electively, if there is a chance of compromise, you need to go ahead and intubate them early. Okay, fine. Thank you.